Some children, at first, really do look autistic. They avoid eye contact. They do not respond. They speak less and less. And sometimes, their emotions spiral out of control. But what is even stranger is this. Every time they get a fever, every time they get sick, it is as if they suddenly slip backward. It can look like encephalitis. It can look like a developmental or behavioral disorder. Sometimes, it looks like a purely neurological problem, or even a psychiatric one. But sometimes, the real problem is not psychological. It is not about parenting. It is not about education. And it is not just inflammation. Sometimes, the real problem lies deeper, in the brain's most basic metabolic machinery. That is what happens in Thiamine Metabolism Dysfunction Syndrome Type 5, or THMD5. It is a treatable, inherited metabolic disorder. It is linked to the TPK1 gene. The problem is not that the child is not getting enough vitamin B1. The problem is that once vitamin B1 enters the body, it cannot be efficiently converted into the form the brain actually needs to function. And the result is this. Again and again, after a fever, symptoms get worse. After an infection, development slips backward. The child falls into a metabolic crisis. But the most important thing to remember is this. This is not a condition without options. If it is recognized early and treated early at the level of the true cause, then for some children, language can improve, social connection can improve, and even those symptoms that seem psychiatric or behavioral may still have a real chance to change. Chapter 1. A real patient story. At first, she looked like encephalitis. Later, she looked like autism. But the real problem was a breakdown in thiamine metabolism. Scene 1. She did not slowly start to seem different. It was sudden, as if someone had flipped a switch. This little girl had been developing normally. She was born premature at 35 weeks. Then, at age 2, she suddenly developed an encephalopathy-like episode. She also had seizures. At the time, there was no clear trigger. Her MRI showed abnormal signals in areas including the bilateral white matter and the caudate nuclei, but her lumbar puncture did not show any clear abnormalities. So at that point, doctors diagnosed her with acute disseminated encephalomyelitis, or ADEM. She was then treated with 5 days of intravenous methylprednisolone. She improved. The seizures stopped. 7 days later, she seemed to be back to her original neurocognitive baseline. And when MRI was repeated 6 months later, those earlier abnormalities had faded. At the time, anyone would have thought this looked like an inflammatory storm that had already passed. Scene 2. What truly frightened her family was not that hospital stay. It was what came after. After she went home, it was as if she never fully came back. Over time, her parents began to notice that her development was slowing down. Compared with other children her age, she was struggling more and more. By age 3, she was diagnosed with autism spectrum disorder, or ASD. If the story ended there, it would have sounded like a familiar explanation. After encephalitis, the child fell behind, and later she was seen as autistic. But that is not where her story ended. Scene 3. She was not always like that. She would regress every time she got sick, and when she regressed, it would last for 2 to 3 weeks. Her family noticed that whenever she became ill, or after vaccination, she would clearly decline. And that decline often lasted 2 to 3 weeks. Only after that would she slowly make it back to something close to her usual self. That pattern, recurrent, fluctuating, coming and going like the tide, was already quietly telling everyone something important. This might not be just a developmental issue. Scene 4. The most heartbreaking part was not simply that she felt unwell. It was that during these episodes, she seemed to lose touch with the life she used to know. Each time it happened, she became agitated, irritable, and easily upset. Words she had once used became fewer. Her expressive language clearly declined. She would refuse to eat, refuse to walk, refuse to take part in everyday activities. Even something as ordinary as brushing her teeth, something routine for most children, she would refuse to do. This was not just a child having a bad mood. This was a child who, with each episode, was losing language, cooperation, and the ability to participate in daily life, little by little. And what made it even more frustrating was this. Every time she had an episode, blood tests were repeated. They looked for infection. They looked for inflammation. They looked for metabolic problems. They looked for hematologic abnormalities. And again, none of it gave a truly clear answer. Scene 5. By the time she had another episode at age 4, everyone knew this was no longer something that could be explained away with. Let's just keep watching. 2 weeks after vaccination, at age 4, she declined again. This time, she had episodes of agitation, intermittent fever, altered mental status, and difficulty walking. On neurologic examination, there was no obvious ataxia, no dysmetria, no seizure activity, and no focal neurologic deficit. But she did have mild encephalopathy, and when she walked, she had already developed a broad-based gait. After hospitalization, that gait gradually improved over the next 3 days, even without any specific intervention. At the same time, her lab tests and imaging were relatively stable, so even a repeat lumbar puncture was deferred. This is exactly where misdiagnosis becomes so easy. A child, again and again, develops agitation, changes in consciousness, and functional decline after fever or physiologic stress. But once she reaches the hospital, she seems to improve just a little. That is precisely the kind of pattern that can send people down the wrong diagnostic path. Scene 6. What finally opened the door to the real answer was not a new inflammatory marker. It was a genetic report. Because this child's course was not typical, and it was not a one-time event. Later, her doctors ordered whole exome sequencing, and when the results came back, they finally found the critical clue. She was found to carry compound heterozygous pathogenic variants in the TPK1 gene. At that point, the diagnosis finally changed. From DEM at the beginning to ASSD later on, and finally, the real diagnosis came into view: Thiamine Metabolism Dysfunction Syndrome, Type 5, THMD5. Scene 7. And then, the story suddenly changed direction. She began to regain language. She also began to regain eye contact. Once the diagnosis was confirmed, she was started on treatment: high-dose thiamine and biotin. Within 6 weeks, her family noticed a dramatic increase in her spoken language. At the same time, her eye contact improved. And those repeated episodes of agitation never came back. This was not the kind of improvement that feels vague or easy to overread. It was a change her family could see very clearly. The child who, during her episodes, had stopped talking, stopped looking, and stopped engaging with the world around her, began to come back out into the world again. Scene 8. What was most striking was not simply that one diagnosis was later withdrawn. It was that the true cause, which had been hidden behind the symptoms the whole time, was finally found. By 5.5 years old, this girl had remained stable. There were no further episodes of behavioural dysregulation, no focal neurologic deficits. Her mother mentioned only that she occasionally had some school-related anxiety. But more importantly, from that point on, even when she got sick, she no longer had those repeated episodes of developmental regression that seemed to pull her backward each time. In her mother's eyes, she was now not noticeably different from other children her age. And perhaps the most symbolic moment was this. The paediatrician who had originally diagnosed ASD later withdrew that diagnosis. And on her most recent Vineland-3 assessment, she showed age-appropriate functional abilities across domains. But one point has to be made very clearly. This does not mean her autism was cured, and it does not mean the earlier ASD diagnosis was entirely wrong. A more accurate way to understand this case is this. At that time, this child truly did show symptoms that fit within the diagnostic framework of ASD. It was only later that people realized those symptoms were being driven by a deeper, more hidden cause. TPK1 related, THMD5. Once the true cause was identified and treatment was finally aimed at the root problem, the symptoms that had once been strong enough to support an ASD diagnosis gradually receded. What changed was not just a label. What truly changed was the underlying metabolic disease process that had been producing those symptoms all along. Scene 9. What makes this case so painful is how convincingly she once looked like autism, and also like encephalitis, like ADEM. Those are exactly the kinds of directions these children are often misdiagnosed into. Because in THMD5, brain imaging abnormalities can be bilateral and non-specific, and its encephalopathic episodes can easily make clinicians think first of neuroinflammatory disease. That is why, when a child initially looks like ADEM, but later develops an atypical, chronic, and relapsing course, we cannot stay fixed on the first diagnosis alone. We need to go further. We need to consider genetic, metabolic, and biochemical testing. Scene 10. What this case ultimately leaves behind is not just the name of a rare disease. It leaves behind a message that deserves to be repeated again and again. Some children look like they have encephalitis. Some children, later, begin to look more and more like autism. But in this girl's case, the real problem was not simple inflammation, and it was not a fixed behavioural label. The real problem was TPK1 related THMD5. This case reminds us once again, recognise it early, intervene early. That really can change long-term neurocognitive outcomes. For this child, that meant more than the end of new episodes of agitation. It also meant that language came back, eye contact came back, and even the ASD diagnosis that once seemed fully established was ultimately withdrawn. Chapter 2. What exactly is THMD5? THMD5 is not a name most people have heard before, but what makes it truly dangerous is how well it can disguise itself. Its full name is Thiamine Metabolism Dysfunction Syndrome type 5. The abbreviation is THMD5. You may also see it written as TMDS5. This is an autosomal recessive inherited metabolic disorder, an inborn error of metabolism, or IEM. More specifically, it belongs to a group of IEMs in which the problem lies in vitamin or cofactor metabolism, and in this case, the problem traces back to one gene, TPK1. So what does this gene do? Its job is to convert ordinary vitamin B1, also called thiamine, into the active form the body can actually use, TPP, or thiamine pyrophosphate. You can think of TPP not as the raw material, but as the key that actually starts the engine. Without that key, many important metabolic reactions simply cannot run the way they should. And TPP is not involved in just one small pathway. It plays a role in multiple critical pathways, including some of the most important steps in energy metabolism. So at the core of THMD5, the problem is not that the child is not getting enough vitamin B1. The problem is that once vitamin B1 enters the body, it cannot be efficiently converted into the form that actually works. That is the key point. The issue is not that it was never taken in. The issue is that it cannot be used properly. And that is why, when TPK1 is not working correctly, the consequences do not stop at a little less energy. It may also disrupt glucose metabolism, lipid metabolism, and nucleic acid synthesis, as well as many of the metabolic pathways the nervous system depends on to function normally. That is why THMD5 is never a one-faced disease. Its presentation can vary widely. In milder cases, it may show up as recurrent episodes of encephalopathy, ataxia, abnormal muscle tone, dysarthria, seizures, and developmental regression. In more severe cases, it can present in infancy with a serious Lee-like phenotype, sometimes along with severe seizures, feeding difficulties, and even progressive neurodegeneration. According to a 2025 review, the published literature has summarized about 32 reported cases. The age at onset has ranged from as early as 1 month of age to as late as 7 years. Among those cases, 75% developed symptoms before age 3 and 37.5% before age 1. That tells us something important. This is not a disease that shows up in only one way. It is a spectrum. It can be mild. It can be severe. It can relapse again and again. Or it can gradually leave behind lasting neurologic damage. And that is exactly why it is so easy to misdiagnose. It is not like some other IEMs, where the classic signs seem obvious from the very beginning. Instead, many children at first only seem a little slow, a little clumsy, or as if they sometimes slip backward. But once infection, fever, dehydration, or another stressor hits, the problem can suddenly break into the open. A child may abruptly develop encephalopathy, worsening gait, abnormal muscle tone, developmental regression, or even a change in consciousness. And then, once that crisis passes, the child may seem to come back at least a little, and because of this recurrent fluctuating pattern, coming and going like the tide. THMD5 is especially easy to mistake for encephalitis, ADEM, cereballitis, Lee-like encephalopathy, episodic ataxia, or even ASD, or a developmental or behavioral disorder. But the real problem is often not those surface-level labels. The real problem lies deeper. Vitamin B1 is not being successfully turned into the active coenzyme the brain truly needs. Chapter 3. What is really broken is the step that turns B1 into a usable metabolic key. If you imagine the brain as a city running day and night, then glucose is the fuel, the mitochondria are the power plants, and TPP is more like the pass that allows fuel to enter the core energy generating process. Without that pass, it is not that the fuel never arrived. It did arrive. It just cannot get through the most critical step. That is the central metabolic logic of THMD5. When TPK1 is impaired, TPP levels fall. And once that happens, the important metabolic reactions that depend on TPP begin to slow down and function poorly. The most immediate effect is on the brain's ability to move glucose into the mitochondria's high-efficiency energy pathway. The result is this: pyruvate has a harder time moving smoothly into downstream oxidative metabolism. Lactate is more likely to build up, and the cell's ATP supply becomes fragile. So at its core, THMD5 can be understood as an inherited metabolic encephalopathy centered on disrupted brain energy metabolism. This is not simply a matter of poor nutrition, and it is not an ordinary vitamin deficiency. It is more like this: the raw material has been delivered. The machinery is still there, but the key that lets that raw material enter the main engine is broken. But the damage THMD5 causes to the brain may not be explained by energy failure alone. From what we know about thiamine biology, low TPP may affect more than glucose metabolism and mitochondrial energy production. It may also disturb broader cellular metabolic homeostasis. That includes lipid metabolism, nucleic acid synthesis, and the cell's ability to respond to stress. At the same time, thiamine and its phosphorylated forms are also thought to be connected to antioxidant defense and neurotransmitter-related function. That means the neurologic problems seen in THMD5 are probably not caused by a single hit. They are more likely the result of multiple layers of injury stacking on top of one another. An energy crisis on one side, more oxidative stress on the other, and, on top of that, disrupted neurotransmitter-related function. That said, the parts involving lipid metabolism, nucleic acid metabolism, antioxidant pathways, and neurotransmitter biology are still, at this point, mainly mechanistic inferences based on biochemistry and prior research. That does not mean each of these processes has already been directly demonstrated, one by one, inside patients with THMD5. But based on the evidence we do have, THMD5 is clearly not a simple one-track disorder that only leaves the brain short on energy. It is more like a metabolic system falling out of balance, layer by layer, until that crisis finally breaks out in the nervous system. Chapter 4. Why does the nervous system get hit first? Because the brain is one of the organs least able to tolerate an unstable energy supply. The nervous system depends heavily on TPP. That is because it depends heavily on glucose metabolism. And this is especially true early in childhood, when the brain is developing rapidly. Synapses are being remodeled. Neural networks are being built. The whole system is running at high speed. At this stage, energy demand is enormous. The brain does not have the same kind of buffering capacity that fat tissue or skeletal muscle may have, And unlike some other tissues, it cannot easily make do for very long when energy delivery falters. So once TPP becomes insufficient, the first regions to fail are often the ones with the highest energy demand and the least tolerance for interruption. That also helps explain why many children with THMD5 show MRI abnormalities in high energy regions of the brain. For example, the basal ganglia, the striatum, the cerebellum, and the dentate nuclei. But this is also where the disease can be especially deceptive. Not every patient has an abnormal brain MRI at the beginning. In some children, imaging can even look normal early in the course. So a normal MRI at one point in time does not rule out THMD5. And because the nervous system depends so heavily on this pathway, THMD5 keeps returning with neurologic symptoms again and again. On the surface, those symptoms may look like encephalitis, a developmental or behavioral disorder, neuroinflammation, a mitochondrial disease, or even autism. But the thread that connects all of these presentations is actually the same. The brain's metabolic system can no longer hold up under stress. That is why THMD5 can be understood as a disorder in which the brain's power system is inherently unstable. It is not because the child does not want to engage, and it is not because the child's personality suddenly changed. It is because when the metabolic pathway falls out of balance, the brain often loses first the functions that are most delicate and most dependent on a continuous supply of energy. Functions like language, movement, social responsiveness, emotional stability, and the ability to participate in the world around them. From that perspective, the neurologic symptoms seen in THMD5 are best understood within the framework of an inherited metabolic encephalopathy. Chapter 5. Why do children seem to regress every time they get sick? Why is it that after a fever, after an infection, a child can seem to suddenly slip backward? The answer is actually not mysterious. Fever, infection, and dehydration can all do three harmful things at the same time. First, they sharply increase the body's metabolic demands. Second, the child often cannot eat well or drink enough. Intake drops. And third, the body is pushed into a state that is much more likely to decompensate. For a child with THMD5, what is that like? It is like a city whose power supply is already under strain. Then suddenly, the weather turns hot. Electricity use surges. And at the same time, some of the fuel trucks stop running. That whole city is going to start losing power. And that is why, when a child develops a fever, you may suddenly see agitation, irritability, worsening gait, less language, and a loss of the social responses they once had. This is not a personality problem, and it is not just a temporary setback. It is the brain falling into a true energy crisis. Chapter 6. Why do some patients seem to get better once they are hospitalized? There is another part of THMD5 that can be especially misleading. Many children, once they are admitted to the hospital, seem to improve at least a little, and this is one of the ways THMD5 can fool people. Each time the child is hospitalized, their condition gets a little better. And that makes it easy to think, did we treat encephalitis correctly last time? Were the steroids actually working? But in many cases, that is probably not the best explanation. Once a child is in the hospital, doctors usually begin a range of supportive treatments. They give fluids, they lower the fever, they correct dehydration. They make sure the child gets enough calories They try to reduce catabolism. They treat infection, and in doing so, they reduce the brain's energy burden. Those measures may be enough to temporarily ease that metabolic crisis. So the child seems to be pulled back, at least for a moment, from the edge of the cliff. And on the surface, that can look like improvement. But if the real cause is still not recognized, then the next infection comes, and the child can fall again. That is another reason THMD5 can be so deceptive. It can improve in phases, but over time, it may still leave behind gradual neurologic damage. So when a child looks better for a short time after hospitalization, what that more likely means is this: supportive care has temporarily eased the metabolic crisis. It does not necessarily prove that a specific treatment has truly reached the root cause. And we also cannot say, simply because a child improves in the hospital, that a metabolic disorder or an inflammatory disorder has been ruled out. What truly changes the long-term trajectory is often not the hospitalization itself. It is timely diagnosis, and then, as early as possible, treatment directed at the real cause, including high-dose thiamine. Chapter 7. How is THMD5 diagnosed? So how do you even begin to recognize a disease like this? The most important first step is actually not a specific lab test. It is this: you have to think of it first, because THMD5 does not present in a neat, predictable way, and the biochemical clues are not always obvious. That is why clinical suspicion matters so much. Part 1. Start with the clinical clues. If a child has the following features, THMD5 should be included in the differential diagnosis. Symptoms begin in early childhood. The episodes recur, and with infection, fever, or other forms of stress, the child is prone to decompensation. What may appear? Ataxia, abnormal muscle tone, dysarthria, seizures, developmental regression, changes in consciousness. In some reported cases, there is also clear neurobehavioral decline, language declines, social engagement declines, and in some children, it can even look very much like ASD. On imaging, brain MRI often shows abnormalities involving the basal ganglia, the striatum, the thalamus, and the dentate nuclei of the cerebellum. In a smaller number of cases, the brainstem, the corpus callosum, or even the spinal cord may also be involved. But one point is especially important. Not every child has an abnormal MRI at the beginning. In some patients, imaging can be completely normal early in the disease course. So with children like these, we cannot stay trapped inside only one frame: encephalitis, ADEM, Lee syndrome, developmental delay, or autism. Part 2. Then look at the metabolic and biochemical clues. Here is one very easy mistake to make. Total blood thiamine can be normal, and yet the truly active form, TPP, may still be low. So a normal routine vitamin B1 level in blood does not rule out THMD5. Because the problem is not whether thiamine was taken in. The problem is whether it can be activated. A more useful clue is TPP itself, the active form. For example, whole blood TPP or TPP/THDP measured in other specimens. Among these, whole blood TPP measurement has been considered a relatively quick and practical diagnostic tool. It can help support the diagnosis of TPK, one related disease, and it can also be useful for follow-up monitoring. In addition, During metabolic crisis, some children may show elevated blood lactate, elevated CSF lactate, or elevated urinary alpha-ketoglutarate. But these findings do not appear every time, and not every child will have them, so they can serve as clues, but they cannot, by themselves, confirm the diagnosis, and they also cannot, by themselves, rule THMD5 out. Part 3. Finally, use genetics to confirm the cause. In the end, what usually confirms the underlying cause is genetic testing. In other words, molecular testing. But to be more precise, it is not as simple as finding one genetic variant and calling it done. What really matters is putting the whole picture together. The clinical presentation, the biochemical clues, and the genetic findings. That is why, in real life, the diagnosis is often not a straight line. Usually, it works more like this. First, you suspect it based on the symptoms. Then, you use metabolic testing, biochemical clues, and imaging to gather support. Then, you look at functional markers such as whole blood TPP. And finally, genetic testing reveals biallelic pathogenic variants in TPK1, confirming the diagnosis. But there is one more clinical point that matters a great deal. TPP testing and residual enzyme activity studies are not easy to obtain everywhere. So in practice, if there is already strong suspicion that this is a treatable inherited metabolic disorder, clinicians should not simply wait for every result to come back before doing anything. In many cases, early empiric thiamine supplementation may matter even more. Because with a disease like this, even a small delay in time can lead to a very different outcome. Chapter 8. How is THMD5 treated? So, can this disease be treated? Yes, but the key is not just giving a few vitamins. What really matters is this: recognizing it early and starting high-dose thiamine early. Because the problem in this disease is not that vitamin B1 never got into the body. The problem is that once vitamin B1 enters the body, it is not efficiently converted into the active form that actually works. So the core of treatment is not ordinary nutritional supplementation. The real goal is to use high-dose thiamine early to push through a metabolic pathway that has become blocked. Part 1. High-dose thiamine. At this point, the most important treatment for THMD5 is still high-dose thiamine. In some patients, clinical symptoms do improve after treatment begins, and in general, the earlier treatment starts, the better the chance of preventing further metabolic decompensation. In some children, later development can even come close to normal. But this part has to be said honestly. Not every patient has that kind of dramatic, clear-cut reversal. This disease is treatable, but that does not mean it is uniformly curable. Early treatment is usually associated with better outcomes, but the response varies widely from one patient to another. Some improve a great deal, some improve only modestly, and in general, the later treatment begins, the more severe the disease is, and the lower the residual enzyme activity, the less benefit treatment is likely to bring. At present, about 27% of treated patients have not shown an obvious response to thiamine. That may be related, at least in part, to very low residual enzyme activity in some patients. So what we see is this. In some milder cases, or in children recognized early, the improvement can be striking. But in some severe Lee-like cases, Even after high-dose thiamine has been started, patients may still be left with severe neurologic injury or even die during a metabolic crisis. Part 2. Are other treatments used, along with thiamine? In some cases, doctors may also use biotin or magnesium along with thiamine. But at this point, these are better understood as adjunctive treatments. They are not considered standard therapies on the same level as thiamine itself. Let's start with biotin. Right now, it is best thought of as a supportive option, and the evidence for it is weaker than the evidence for thiamine. Most of the support comes from case reports using combination therapy, so exactly how much benefit biotin provides on its own is still not clear. Now magnesium. Magnesium is a known cofactor for TPK1, so mechanistically there is reason to think it may matter, but so far it still remains mainly an adjunctive strategy described in case reports. It is not yet considered standard treatment. There are reports in the literature like this. One infant with recurrent fever-triggered encephalopathy was started on high-dose thiamine plus magnesium. Within days, alertness, ataxia, and muscle tone all showed clear and sustained improvement. There is also another reported infant who was recognized relatively early and treated with oral thiamine plus biotin. Later, psychomotor development was close to normal. It is reasonable to suspect that early diagnosis and early treatment played an important role there. Part 3. One important point that is often overlooked. There is another question that deserves attention. If the key bottleneck in this disease is the step that converts thiamine into TPP, then in theory, would it be even better to give TPP directly, the active form itself? Mechanistically, that idea makes sense. But the practical problem is that in many countries and regions, TPP is not a widely available medication. So in real-world clinical care, what can usually be done
is still to start high-dose thiamine as early as possible, especially in situations like this. The clinical suspicion is already high, but rapid biochemical results are not yet available. In that setting, while waiting for WES, whole exome sequencing, trying high-dose thiamine early is often meaningful, because in a treatable inherited metabolic disorder like this, time can sometimes be the difference between what is reversible and what is not. Part 4. Treatment is not enough if triggers are not prevented. Medication matters, but there is something else that matters too. As much as possible, we need to prevent the child from being pushed into another metabolic crisis. The most important triggers to actively prevent in THMD5 are infection and fever. Then come trauma and other forms of stress that push the body into a catabolic state. Clinically, we also need to be alert for gastroenteritis, vomiting, diarrhea, poor intake, inadequate drinking, dehydration, and prolonged fasting, because all of these can gradually push a patient toward metabolic decompensation. And for patients who have already been diagnosed, there is another important risk, one that is often preventable. Stopping high-dose thiamine without medical guidance. That too may become an important cause of relapse. There is also one more question that worries many parents. What about vaccines? And this point needs to be stated clearly. So far, the literature includes only a small number of cases in which episodes occurred after vaccination in terms of timing. But that is still not enough to prove that vaccines themselves are a common causal trigger of THMD5. So it would be too simplistic to say, then no more vaccines. A more reasonable approach is this. Vaccinate when the child is clinically stable and does not have a moderate or severe acute illness, and make a monitoring and emergency plan around vaccination together with the metabolic and neurology teams. And there is one more important point. Some patients may still have episodes even without a clearly documented infection or fever. So avoiding triggers can reduce risk. But it cannot replace long-term maintenance treatment. And it cannot replace a plan for managing acute illness.
Closing, the most important thing to remember about this disease is not a gene name, it is a reversal. What makes THMD5 so striking is not simply that it is rare, it is that it turns some of our most familiar clinical impressions upside down. What you see is this: a child who stops talking, stops making eye contact, and becomes emotionally dysregulated. It looks like autism. What you see is this: after a fever, the child cannot walk steadily. It looks like encephalitis. What you see is this: abnormal signals in the basal ganglia on MRI. It looks like Lee syndrome. What you see is this: the child seems a little better in the hospital, then worsens again after going home. It looks like something that just keeps relapsing. But if you keep looking one layer deeper, you begin to see something else. The real problem is not the surface label. The real problem is the brain's most basic energy system. It is not that the child does not want to connect. It is that the loss of language and social function may be the result of brain dysfunction during metabolic crisis. It is not that parents are imagining things. It is that every infection may be pushing a hidden metabolic crisis out into the open. And most importantly, this is not a disease in the face of which we are completely powerless. The most important lesson THMD5 leaves behind for clinicians and families may be this: symptoms that look psychiatric are not always primarily psychiatric, because the neurodevelopmental and neurobehavioral symptoms seen in THMD5 may arise secondarily from an inherited metabolic encephalopathy. And in the same way, episodes that look like neuroinflammation may not be inflammation itself. Very often, the answer is buried much deeper. It may be hidden in a metabolic pathway, hidden in a whole exome report, and hidden in a question that seems small but actually changes everything. Can vitamin B1 be successfully converted into the active coenzyme the brain truly needs? If you are interested in inborn errors of metabolism, or IEMs, and in the connection between neurologic or psychiatric symptoms and inherited metabolic encephalopathies, you can find the full written version in the Shunyi series.